Hi, good evening, everybody. This is Dr. Salvatore Docimo, Assistant Professor of Surgery at Stony Brook Medicine in the Division of Bariatric, Foregut, and Advanced Gastrointestinal Surgery. Tonight, we're in the SAGES Bariatric Devices Resident webinar, and our faculty joining tonight to comprise our expert panel is going to be Dr. Caitlin Halbert, who's over at the Christian Institute of Advanced Surgery in Newark, Delaware. Dr. Jean Mikami, Associate Professor of Surgery, Division Chief General Surgery at the John A. Burns School of Medicine. Dr. Erik Wilson, Professor of Surgery and Vice Chair of Surgery, and also Medical Director of Bariatric Surgery and Division Chief of MIS and Elective General Surgery at the University of Texas in Houston. And also Dr. Santiago Horgan, who is Professor of Surgery and Director of Center for the Future of Surgery at UC San Diego Health. Just a few pointers before we get started. If you want, you can use the chat pod located on the left hand of the screen to type your questions to the panel. If you happen to lose audio or video, you can exit the webinar, close out of your browser, relaunch your browser, and then log back into the show. If these problems persist, you can go ahead and try to restart your computer machine. At the end of the show, there will be a web link to the SAGES survey. Please, we encourage you to take the survey. This will allow us to make our upcoming events even better. And this entire show will be recorded, so in the coming weeks it should be viewable online at www.sages.org. And just of note, we do ask if you can, please go ahead and try to join SAGES today after the seminar tonight and webinar. Please go ahead and join it at www.sages.org/membership. Becoming a member of SAGES will allow you to have substantial discounts for any of the future meetings. It's a great way to kind of meet future developing surgeons and also meet some of our experts. And then also, I think more importantly, it does offer member-only research grants and also career development awards. So it's an excellent group to be a part of, and I highly encourage you to go ahead and try to join at the conclusion of our seminar this evening. So I think we'll get started here. Our first expert on the panel is going to be Dr. Halbert. She's going to be talking about intragastric balloons. And Caitlin, if you want, can go ahead and take it away.
Thanks, Sal. Appreciate it. So again, coming from Newark, Delaware, I want to give a shout out to everyone who's listening at Christiana, all my residents. Really appreciate you guys coming out and supporting me. So today we're going to talk about intragastric balloons. And we're going to talk about a lot of devices tonight. But my disclosure is just for tonight. I do work for Gore as a speaker. I do actually offer reshaped balloons to my patients. So for each of the devices that we talk about tonight, there's a couple things that we need to talk about that are important, right? What is it? What are we trying to do with these devices? Who is it actually for? It's going to differ slightly for each of these tonight. How is it performed? It's really important, right? Does it work? That's the most important thing. Does it actually do its job, and is it safe for our patients? We're going to be answering each of these questions for each of the devices that we talk about tonight. So the intragastric balloons are actually not new. The Guerin Edwards gastric bubble was actually the first intragastric balloon that was utilized in the 1980s. It was actually FDA approved after a small study of 100 patients, and is the first endoscopically placed balloon. So, and you see that it has oblong shapes and very novel for the time. It actually was first developed in Wilmington, Delaware, so it's a little close to home for us. There's two GI docs in Wilmington, Delaware, who developed this balloon. It's kind of their little claim to fame around here. Well, the problem is that this balloon had a lot of issues with mucosal damage, ulcerations. They would deflate very easily and cause bowel obstructions. And actually, if you look at some of the studies, there's one study I was reading where 275 balloons were placed. 33 of them were removed endoscopically, so that means 2/3 of them were not removed endoscopically. The majority of those passed per rectum, actually, but some of them got.
Hey, Caitlin?
Yeah.
Hey, can you share your screen? Because we're having a problem just seeing it on our end here.
They should see it. We should be on a screen share, actually. Hold on a second here. Mm-hmm. Let me go back.
And I see your screen now, so you should be good to go.
Great. Thank
this is
you
great.
So much. Awesome.
Thanks. Yeah, or as we had to use our imagination,
Yeah, no, it's good. So
okay, looks great.
Yes, this is what the bubble looks like. But this is the problematic bubble. So this is the balloon that ended up having issues with ulcerations, valve obstructions, and they just deflated very easily. So, and they got stuck at the ileocecal valve. There was a high rate of surgical intervention that was needed for valve obstruction. So these fell out of favor very quickly. And then the idea of an intragastric balloon was really abandoned for 3 decades essentially. And so there are this rejuvenation of the idea of intragastric balloons, but it's not the only endoscopic treatment for obesity. And you can see here, this is from SWORD 2016, and there's a long list of procedures out there, endoscopic procedures for obesity. You see Pryor sits at the bottom there. Something more recently has gained FDA approval. And under intragastric balloons, you can see there's a long list of balloons, but we're going to talk tonight specifically about the 3 balloons that have gotten FDA approval. So you can't just build an intragastric balloon or an endoscopic procedure for obesity and just put it on the market. Of course, it has to get FDA approval, but you also have to meet certain standards. And ASMBS, the American Society for GI Endoscopy, jointly put together some primary endpoints that they want to see for any endoscopic treatments for obesity. In the first year of treatment, they want to see an excess body weight loss of 25% in patients, and they want to see no serious adverse events that go above 5%. So that's kind of the standard that we're looking at for each of these procedures. So the 3 balloons that we're going to talk about tonight are Reshape, Orbera, and Obalon. And while I do place the Reshape, I was actually part of the clinical trial for Obalon, so I have experience with both of those. And I'm going to talk to you a little bit about how each of these differ. So this is what they look like. The Reshape balloon there on the left, the Orbera in the middle, and the Obalon on the right. Now, the Obalon does not float in space, but is air-filled in comparison to the 2 on the left that are fluid-filled. So you have single and dual balloon systems. The theory behind the dual balloon system is that this rests more gently along the curvature of the stomach, has a little bit of a bend in it versus one large single balloon, but we'll talk about the nuances of each of these balloons. So here's a head-to-head comparison. Now, the Reshape balloon is, of course, a dual balloon system. The Orbera is a single balloon, and the Obalon is actually 3 sequentially placed single balloons. The Reshape and the Orbera are both endoscopically placed and endoscopically removed, so each of them are outpatient procedures. The Obalon is actually the pill that you swallow, but it has to be endoscopically removed. So we'll talk a little bit more in a couple slides about what that capsule actually is. The Reshape and the Orbera are fluid-filled. They have saline and methylene blue. Now, the reason behind the methylene blue is that if any of the balloons deflate during their 6 months in the patient would pee blue or green, and it would alert them to come to their surgeon for evaluation. I've had some patients that worry that they may have a little discoloration of their urine, so they call me up and they bring them in, and I get an x-ray with a little bit of contrast to see if I can see 2 perfectly round balloons sitting in the stomach. If for some reason I can't see that clearly on an x-ray, then I will bring them in for repeat endoscopy, and I just want to ensure that those balloons are both up. The nice thing about the Reshape balloon versus the Orbera is that if one of the balloons go down, the other balloon will keep it pre-pyloric. And so that is a little bit of a safety mechanism with the dual balloon. They've never had any post-pyloric migrations of the Reshape balloon because of that dual balloon factor. The Reshape balloon, and the Orbera both, depending on the patient's height, will get different fluid amounts within those balloons. So up to 900 ml total in the Reshape balloon, and the Orbera can go up to 700 ml. The Obalon balloon is actually gas-filled. So it's a mixture of different types of gases within a canister, and 250 ml go into each balloon. So if you get 3 balloons, 750 total. Now, each of these balloons will stand for 6 months. That is it. They are not approved for beyond that. And I have my patients sign a really strict contract, essentially. It's their consent, but saying that they have to come back and have these removed at 6 months. They can't go off and keep them in there for longer because they're really not approved. And what I've noticed, actually, once the balloons are getting closer to that 6-month mark and we're taking them out, the methylene blue actually starts to get absorbed within the wall of the balloon, and so the fluid inside the balloon becomes less and less died. So it's really important, I think, to get those balloons out at 6 months. And so I talk to the patients all the time about that. So, and then for each of these balloon systems, included in the cost of the procedure is 12 months of nutritional coaching. And so, as you may imagine, these balloons are not covered by insurance. So for most balloons that are placed in most facilities, the cost of the balloon includes the placement, the removal, the 12-month nutrition classes, plus or minus your consultation in the beginning, and it also will cover any issues that you may have during those during that 6 months especially. Now, patients between a BMI 30-40 are meet indications according to FDA approval for these balloons. For contraindications, so anyone that's had foregut surgery, this is incredibly important. I have a lot of patients coming in that have had the band removed, or maybe even still have the band, and they want the balloons on top of it. That is an absolute contraindication. Any type of surgery to the stomach is a contraindication. You don't want to have the scar tissue, because I think that really what can happen is you just increase your risk of erosions and ulcerations. Any large hiatal hernia is a contraindication, but I have had a few patients with a small sliding hiatal hernia. They are fine to have the balloons. Anyone that has recurrent ulcers, certainly if anyone has a mass, or severe reflux, that's a contraindication. If I get in there, and I always do a diagnostic endoscopy before placing the balloon, and if I see something suspicious for Barrett's, I will biopsy it and we'll come back another day, because we don't want to be encouraging more reflux placement of these balloons going into the future. So how is it placed? So this works. Yay. So this is the reshaped balloon, but this is placed very similar to the Aurora. And so I actually put my patients under MAC anesthesia for placement, but I actually do general for removal. So they go under MAC for placement. I go in with the diagnostic endoscope. I make sure that there is a large hiatal hernia, there is a severe reflux, there's no masses or ulcers. And then I place a guide wire through the pylorus, and over the guide wire place the device. And then under visualization, we fill it up with the saline and methane balloon mixture. And then the device will detach and we'll be able to pull it out. Removal is a little bit different. We go in there and we deflate, and we actually have to lasso a piece of it to take out, and I'll show you that in a couple of minutes. But because of the fact that we are deflating and there's all this fluid that can potentially spill into the stomach and then also aspirate into the upper airway, I take control of my patient's airway, so I opt to place patients under general for removal of the balloons. Now, the Ovalon is a little bit different, as I said. This is a capsule, and it's a big capsule. This is, you actually have to trial your patients before you have them place an actual Ovalon balloon. And so there is a fake capsule, the size of this, that I have patients swallow to make sure that they can actually swallow that without gagging. And so if they can pass that test, then they can go ahead and have the Ovalon. And this capsule, you can see here, is attached to a catheter. This is a self-filling valve attached to a thin catheter. And so the patient stands in the center of a C-arm in a fluoroscopy suite, and they swallow this gelatin capsule. The gelatin is surrounding the balloon that's all wrapped up inside there. And then the catheter is still attached as they're swallowing it and coming out through the mouth. It's a little gag-worthy, but patients tend to tolerate it pretty well. And we're watching the pressure with this device on the right here. We're watching the pressure as it's going down into the esophagus. And so we confirm with the pressure drop as it gets into the stomach, and also, obviously, fluoroscopic guidance to make sure that it is past the GE junction. Once we've confirmed that it's in the stomach, then we can use that same device and that canister there to instill the gas under visualization. And then once that's complete, the catheter can get detached and gets removed, leaving just the balloon in place. Now, 3 balloons, up to 3 balloons can be swallowed during the same time, but really I think it's more advantageous to do this in a sequential session so patients don't become too nauseated. And then all balloons come out at 6 months. Now, this is removal. Each of the balloon manufacturers have special devices that will deflate the balloons. And so this right here, this is a needle that you kind of crank out the needle, it pops to the balloon, and then you can bring the needle back and advance this catheter into the balloon, and it's also a suction device. And so you'll suction the fluid out, and you can see that here. And then there's a little kind of nubbin that you'll see at the edge of the balloon, and you want to lasso that with a snare. Now, sometimes it's really easy to find that, and sometimes it's not really easy. Sometimes you have to flip the whole thing around. So, but you get hold of that, and that comes right out. I will also take actually a rat tooth grasper and punch a giant hole into each balloon just to decompress it even further, so there's no more little air fluid that's in there that can cause some trouble while taking the balloon out. Then I go back in with the endoscope after the balloons are out, and I make sure that there's no ulcerations, no injury to the stomach that may have occurred while the balloon was in place. So there's a lot of studies, right, for each of these things of how they got FDA approval. Each of them had their own pivotal trial. This is the reduced pivotal trial for Reshape. This enrolled 326 patients. They hit 25.1 excess body weight loss versus sham of 11. Now, they had sham endoscopy performed for these patients. Had significant difference there. And, you know, also looking at the bottom here, 2/3 of the patients were able to maintain that weight loss for 6 months after the balloons were actually removed. 66% said that they would do it again, and 3/4 of them said that they would refer it to a friend. So, you know, it's pretty successful and overall pretty well tolerated by patients. They have a deflation rate of 6% in this pivotal trial, lower in commercial setting, but they've had 0 migration. And that's really important, and that was something that was important to our practice when we picked the Reshape device. But one thing that you will find with all these balloons is that patients struggle for the first 3 days. If you can imagine, for the Reshape balloon, for example, there's 900 cc's of fluid in there that wasn't there before, and the body is trying to get rid of it. And so for the first 2 to 3 days, depending on the patient, they have pretty significant nausea, vomiting, and abdominal discomfort. And we start patients on a PPI 3 days prior to the procedure in order to help reduce acid and any reflux that they might incur. And then we give them everything under the sun for antiemetics. And we get them that before they even have the procedure done so that it's at home and ready to go. I also tell my patients to call me early in the morning if they feel like they're getting dehydrated, and I'll bring them straight into our surgery center or into the infusion lab so that we can give them fluids, maybe a shot of Phenergan. And really, this time period is a lot of hand-holding, but once you get through this time period, as you can see here by the numbers, that really resolves, and patients are really able to tolerate these balloons very well. Again, it's the abdominal pain here, mild to moderate recorded scores, but really happening within those first few days. Now, the Aurora pivotal trial looked at 255 patients. This was not a, they did not do sham endoscopy, but so it was a non-blinded study, but they actually had an excess body weight loss of 29% versus 11, so really significant, and this was at 1 year out from balloon placement. They had a 5% device intolerance that required removal, but it's pretty minor, actually. And if you look at some of the issues that they had here, these are the significant events that they had: dehydration, gastric outlet obstruction, gastric perforation, 1 out of 160, but the percentages there you can see are pretty low. And what their major complaints were as far as patients were concerned: nausea, vomiting, abdominal pain. But as you can see right here is that it all resolved within the first few days after the procedure was completed. The Horgan pivotal trial, this was actually a study in Europe, but because this has been studied quite a bit over the last couple of years, and this is looking at not excess body weight loss, but total weight loss, so it's a little bit different percentage, but still met their mark, actually. And I was actually part of this trial, and it's funny because, or one of the more recent trials in the U.S., but it's funny because watching a patient swallow a capsule that is not the balloon is the saddest thing ever, because they go through such gagging to get that in. But that being said, this was a crossover trial, and so they went on to then have the actual Obalon if they wanted down the line. So one serious event in the pivotal trial was peptic ulcer, but really, you know, most of their adverse events were very mild, to 82%, pretty mild to moderate, nothing terribly significant over time. And so patients tend to tolerate this a little bit better. They kind of know what to expect after each balloon. They get a little bit of nausea, maybe some vomiting after each balloon. But because there's only 250 cc's going in at a time, their nausea and vomiting is actually not as severe as some of the larger balloons. Globally, Obalon has been placed in thousands of patients, and they have a less than 0.05 deflation rate and less than 0.01 esophageal rupture. And that's important because the Obalon needs to be close beyond the GE junction. So it's really important to ensure that that is in the stomach so that you don't inflate that balloon inside the esophagus, and that will cause the rupture. All right, so just kind of wrap things up, more recently we've had some alerts come out from the FDA, and I want to address some of those. This is regarding both pancreatitis and overinflation of the fluid-filled intragastric balloon, so this does not include Obalon, but so this is the Reshape and Aurora. And talking to each of these companies, because there's not a lot published right now, the Reshape experience reports 4 cases of pancreatitis, 3 of them requiring balloon removal. So an incident rate of 0.3, but still really important to keep in mind as a clinician doing these procedures that may be cause of some of the abdominal pain if it persists beyond a couple of days after placement. The Aurora has reported 2 cases of this. It's questionable why we're having pancreatitis after these fluid-filled intragastric balloons are placed. Is it a weight issue? Is it an inflammatory issue? Not quite sure, and that's under investigation. The overinflation rate is a little bit more confusing, and it's funny in talking to these companies and trying to figure out why they're having this overinflation problem. They think that it's mostly really just a technical issue. So Reshape has not had any of these overinflation rates or overinflation cases in a commercial setting. They had one in the pivotal trial that quote-unquote resolved with balloon removal. The Aurora has had a lot of them in the commercial setting, 54 reported cases. So I think it's a technical error in overinflating these balloons, but again, still early in the investigation stage of why this is occurring. So probably more to come in the future. So, this is a really exciting time. All these new procedures are coming out. We were the first ones to do an intragastric balloon in the state of Delaware, but the state of Delaware is really small, so it's really easy to be the first one to do anything. So as far as the Reshape balloon, we were the first one, but we have to be really careful because we have to understand what's happening long term. Now the Reshape balloons, they come out 6 months, so okay, we don't need to know that much about long-term studies, but with any of these new procedures, you really should know the ins and outs of these procedures and what to expect and stay up to date with it as new information comes out. And not every procedure is for every patient. And so patients come to me looking for intragastric balloons, and they may not be well suited for it. And you have to sit down and really talk to them about what their expectations are and what their limitations are, because maybe some other procedure would be more suited for them. So that's it that I have on intragastric balloons, and unless we have a couple minutes for questions at the end, but that's up to Sal, I guess.
Hey, Dr. Halbert, excellent presentation. I actually have one question, and hopefully you'll be able to stick around with us toward the end for about 15 more minutes of questions after all the experts are done. But what is your opinion? I know obviously FDA regulation right now, we don't want to go above BMI of 40. Do you foresee, though, the balloons being, acting as a bridge to, from an individual who may present with a BMI of, say, 55, 60, they place the intragastric balloon, get their weight down to a safer BMI, and then move forward with, say, a sleeve or a bypass. Do you foresee that in the future?
Absolutely. I think, well, right now, of course, insurance isn't covering it, so we have a little bit more of leeway. So if anyone comes in with, like, a BMI of 29.6 or they have a BMI of 42.5, I will offer that to them still. But for those higher weights, for not only patients that are bridging to bariatric surgery, but let's say a patient that has to lose weight for a transplant, for some kind of organ transplant. Sure. They would be great to have this. It's short-term, it's low risk, and if we can bridge them to those type of procedures, I think it would be ideal. And now it's hard to get those patients to pay out of pocket for that. But if insurance can find indications like that for our patient population, I think that would be really advantageous. Yeah.
Excellent. Excellent. And we actually have one other question that came through the chat. One individual wanted to know, are these balloons, number one, are they radio-opaque? And also, if they do burst and migrate into, in the small bowel, what is your approach for retrieval? Is it more lap versus open, or have you had any experiences with this?
Yeah, so these Reshape ones are not terribly radio-opaque. They don't have any linear markings or, circumferential markings on them. So that's why I have the patients drink a little bit of contrast for those studies so it can kind of highlight them. I don't believe Oberon or Bear do either. So I just have them drink a little bit of contrast so I can see them. I have informed our ER colleagues about these, given a brief talk to them about it in case they do see them. But patients know pretty well that if there's any issues whatsoever to call us, and we actually have a direct line for balloon patients through our office 24/7 so that they get straight to us so that we can take care of them. So that there's no question and that their care is really streamlined for them. As far as valve obstructions are concerned, thankfully I've not had one. Now, if I were presented with that issue, I mean, just talking to an minimally invasive surgeon, I'm going to do it lap. So, you know, run the valve, find the balloons, and make a small enterotomy and take them out. So that would be my plan. You know, but thankfully I have not had that issue come up yet.
Excellent, excellent. Well, again, excellent presentation, Caitlin, and hopefully you'll be able to stick around for the end, for the last 15 minutes. We appreciate that. So thanks again. Excellent. And okay, so moving forward, we now have Dr. Dean Mikami, again, Associate Professor of Surgery. He's out at John A. Burns School of Medicine, and he's going to be giving us a talk on stoma reduction. So you can take it away. Thanks.
All right. Thank you very much for having me here. So I'm going to share my screen here, and just I'm not sure if you guys can see it yet. How about that? Oh. Okay, so I'm going to get started here. So what I'm talking about today is stoma reduction after Roux-en-Y gastric bypass. So as we know, here are my disclosures, and I don't believe this will have any content in the presentation. So we are doing 150,000 to 200,000 bariatric operations a year now. We know from this study from Dr. Pori's that weight loss is fantastic, and it's 67 to 75% of excess body weight, and 80% of our patients over a 2-year period. And a follow-up study looking at patients at 14 years, at least 95% of patients maintain at least 50% excess body weight loss here. So unfortunately, there are still a big percentage of patients that will regain some weight at 5 to 10 years. So it's estimated that probably 10 to 20% of patients with the Roux-en-Y gastric bypass, and we're not sure what the number is for the sleeve gastrectomy will be. Usually we see a nadir weight loss at about 2 years. That's the honeymoon period. Being in the state of Hawaii here, it's I think 1:30 in the afternoon right now, and it's sunny and bright, and it's 82 degrees here. So there are a lot of people in Hawaii that are interested in weight loss. You think Hawaii is a very healthy state, but just listening to Caitlin's presentation, one of the big things is having patients lose about 50 pounds or so. But the real key is trying to keep that weight off, right, after a 10 or 15-year period. So what is weight regain? So weight regain has been defined as probably gaining 20% of your weight above your nadir weight. So if your nadir weight was 150 pounds and you gain 20% of that, you could be up to 180 to 200 pounds, or dropping below the 50% excess body weight mark after the primary operation. So it's estimated that 12% of patients will have a significant weight regain after gastric bypass surgery. So why is endoluminal procedure so important for the future of our surgery and weight loss surgery? I think the key thing is when you look at revisional, laparoscopic, or open surgery, in this review by Jones, 17 open papers, 838 patients, having a 14% major complication rate and a 1.3% rate of mortality. 64 patients underwent laparoscopic reoperation, 6 major complications for 9%, average OR time at 4.5 hours. So what we're really trying to do is we're trying to make a very difficult operation that we do open or laparoscopically something a little safer and probably more simple to kind of deal with as far as weight regain. So we're talking about 50, 75 pounds, and sometimes even less than that. So historically, endoluminal anastomotic outlet reduction or pouch reduction or stoma reduction has been around for probably the last 10 or 11 years. Some historic endoluminal anastomotic outlet reduction devices that were out there were the EndoCinch by Bard, the Rose procedure, and the StomaFix procedure, which I had a large part of in the past. So new techniques now are endoluminal injection of the anastomosis with a sclerosant, usually sodium morarate. Or probably the biggest thing out there in endoluminal surgery is endoluminal suturing. So moving on to some historic things, the Rose and the other devices. So the Bard EndoStitch was probably came out in the early 2000s. Basically, I think we really started understanding what we could do endoscopically. So it would place a simple suture with a pledget at the very end of it. And what surgeons were trying to do over time was trying to make this the anastomosis smaller when we had a dilated stoma. So typically we see a 15 millimeter to 20 millimeter stomal size, and we could reduce it down to something in the 10 millimeter to 12 millimeter range. Other devices, the Rose procedure, very intuitive type device where you actually have a drivable end effector, and you have these arms that look like almost like a suturing device. Here's a short animation about the Rose procedures for those who haven't seen it before. So basically, you come down into the gastric bypass stomach. Once the bypass was completed and patient had weight regain, you could go in there and actually tighten up the pouch itself and the stoma. So you had 4 working ports. And then you could pass these instruments through the working port to create your what you wanted to do here. So kind of moving on here. You could pick up the stoma. So I think one of these, even though it doesn't look like this will kind of move on, this is one of the first steps in endoluminal surgery that we undertook here. So this device here could place a pledget on one side of the suture, and then on the other side place a second pledget to cinch this down. And when you repeat this multiple times, you could really reduce the pouch size down, and you could reduce the size of the anastomosis. So other suturing devices, the StomaFix device had these polypropylene T-fasteners, and this is what this kind of device kind of looked like here. So same principle, you'd come down the esophagus, and it had the polypropylene fastener was driven on a needle-like device, and then created a pledget into the stomach, or a pleat into the stomach. So the device would come down the esophagus, and you would have a working endoscope, a standard therapeutic or a standard diagnostic endoscope on. The device would suction up tissue and fire it through the wall to create pleats of tissue to reduce the pouch size down and the stoma size down. So here are some of my cases here. So this is what it looked like prior, and then this is what it looked like after the procedure was done. We would actually help patients who had reflux after roux-en-y gastric bypass too by using this device near the G junction. So that was the past, and now this is the future. So truly the two things that are out there today are endoscopic scalar therapy with sodium morarate. So a study by Chris Thompson looked at 231 consecutive patients that underwent 575 scalar therapy procedures between 2008 and 2011. So this is by far the biggest study in the literature regarding endoscopic scalar therapy for weight loss. There have been some studies prior to this with small groups in the 20 to 50 range, but this study is probably the largest one out there. So they looked at weight loss at 6 months and 12 months. And what they found out was that at 6 months, the weight regain stabilized in 92% of the patients, and at 12 months, the weight regain stabilized at 12 months. So using this sodium moderate solution, here this is the measuring device, the endoscopic measuring device of the gastric jejunostomy. This is what it would typically look like right after you injected the agent. And usually you did it in either 4 quadrants or 8 quadrants with half cc to 1 cc in each quadrant. And at the very end, this is what the stoma looks like 3 months later. So on the first one, you can see this black line, 1, 2, 3, 4. Now you have 1, 2, 3. So it kind of reduced it by about 25%. So we're kind of moving in the right direction. So those who underwent more than one treatment or 2 or 3 scalar therapy sessions had a significantly higher rate of weight regain stabilization, 90% versus 60% at 12 months. The average weight loss at 6 months from the last therapy was about 10 pounds, representing about 18% of the weight regain after the Roux-en-Y gastric bypass. A subset of 73 patients, or about 1/3 of the cohort, had a greater weight loss at 6 months, about 26 pounds. So now we're looking at almost patients losing more than 50% of their weight regain. So this represented 61% of the weight regain in this study. So some of the predictive factors for favorable outcome was the number of scalar therapy procedures that were done, and the number of, the more patients or the higher the weight regain, the better the patients did with weight loss with this therapy. There were no GI perforations. Bleeding was reported in 2.4%, and hypotension was, or actually hypertension was reported in 15 cases, or 15% of the patients. So this is a safe and effective tool to use in patients, and this is probably a good start maybe before you go after somebody's stoma with a suturing device. You can see if stoma reduction with sodium moderate will give patients a feeling of fullness and some weight gain early on. So if this works, then probably the next thing you want to do is endoluminal suturing. So this device is called the overstitch device, and basically it's been simplified over the years. Now it's a device you can use where it has a single action jaw. Before it had multiple toggles to it, so now it's much simpler to use. You have to use a 2T 160 scope, so it's a therapeutic scope, so it's a little bit larger to use, and it has end effectors on the end of the endoscope itself. The downside of this is if you have a lesion you want to get maybe in a corner, or if you're trying to go after a sleeve gastrectomy leak or something, it's really hard to get it to retroflex or even look towards the lateral side wall to suture this down. So early on, 22 patients had 11 outlet reductions and pouch reductions. And the average weight loss at 3 months was about 27.5 pounds or 21.5% excess body weight loss. So there was a lot of excitement early in the probably 2010, 2011 time period. Here is a surgeon from Sao Paulo, Brazil, and doing a stoma reduction here. So basically doing an interrupted suturing of the anastomosis. So basically throws an interrupted suture here. And then the next step is to kind of go a little bit over. And what you don't want to do is, really close this thing down, because patients can have very severe dysphagia after. So you probably want to get the reduction down to about 10 millimeters or less. If you're in the 5 millimeter range, you may have to actually stretch that area back out and everything. So Fairly durable. So let's look at some data looking at this. So Mike Ujiki's group out of Chicago looked at outcomes of 50 consecutive endoscopic gastrojejunal revisions for weight regain following room-wide gastric bypass. So what they did was they compared suturing versus stomal reduction. So they looked at 50 patients from 2012 to 2015. Average age was about age range was 18 to 74, at least 2 years after their initial gastric bypass with stomal dilatation of greater than 15 millimeters in diameter. So the revisions were either an IRT or interrupted technique or a purse string technique. So this is what they kind of do. They use some APC to roughen up the edge of the stoma here. You can see this stoma looks very dilated, probably about almost 2 centimeters. Then they go in with the endoluminal suturing device, and they will cinch this thing down. So of the 50 revisions, 36 were done with interrupted suturing or interrupted technique, and 14 were done with a purse string technique. The average BMI was about 42 in this group. They had technical success in all patients, and the stomal diameter was reduced to less than 10 millimeters in size. The final diameter was significantly smaller in the purse string group versus the interrupted suturing group. So we saw some of the early studies looking at just doing simple interrupted suture of the stoma versus using a new technique that Dr. Ujiki's group has used, where they purse string the stomal down. They had greater stomal reduction with the purse stringing, 76% versus 84%. And the purse stringing resulted in greater excess weight loss over time compared to interrupted technique. At 1 year, I think this is the biggest thing in their study, 75% of patients that had the purse stringing technique lost at least 20% of their excess body weight. And in the suturing group, only 23% of that group lost more than 20%. So a huge difference. 75% lost greater than 20% of their excess body weight loss with the purse stringing, and only 1 out of probably 5 lost it with the interrupted suturing. So this is a great study looking at maybe in the future the way we need to tap the stoma is not really with simple interrupted suture, but really by kind of purse stringing this anastomosis down. So another study looking at scalar therapy versus endoscopic suturing. Chris Thompson's group again looking at 43 Roux-en-Y patients with weight regain. 9 patients underwent suturing and 34 patients underwent scalar therapy with sodium mortarate. They looked at weight, they looked at ghrelin levels. The higher the ghrelin level, the better after, and eating behaviors and the outlet size after were looked at. Patients were about 47 years old and had about 43% of weight regain, and the ghrelin levels at the baseline was 123, and outlet diameter was about 21 millimeters in size. So at 3 months, the entire cohort lost about 4.1% and showed improvements in their eating habits. The endoluminal suturing group lost 10.4% of their total body weight. So when you look at total body weight, you usually times it by 2 to get the excess body weight, and that's about 20%. The scalar therapy group only lost 2.7%. The endoluminal suturing group had a reduction of their outlets by 15 millimeters, and the scalar therapy group only had a reduction of about 2.6 millimeters in size. The ghrelin levels increased dramatically after suturing by 46 nanograms per ml, and the ghrelin actually decreased in the scalar therapy group. The suturing resulted in greater improvement in cognitive eating behaviors, and the reduction in outlet size and changes in cognitive and emotional eating behaviors were predictive of weight loss after the gastric jejunostomy and anastomotic reduction. So the key factor here was what they found was the size of the stoma at the end of this time period was the key factor for weight loss, which we would expect. So to sum it up here, I think there's a lot of new things being done. In order for us as SAGES members to stay relevant, we need to all do endoscopy. And, maybe you're not doing therapeutic endoscopy now, but definitely getting your hands on the endoscope, getting in the GI lab, familiarizing yourself with the equipment, see what you have there. Injection scalotherapy is very easy to do, very safe. There are a lot of promising primary and revisional endoscopic procedures for weight loss that are on the horizon. And, the new thing now is the endoluminal sleeves and everything that are being done by suturing. And I think for revision, we can make endoluminal procedures make difficult laparoscopic or open operations much safer for our patients. And I believe this is the future of surgery. Thank you very much for logging in. I'll be happy to answer any questions now.
Dr. Mikami, Sal Docimo, excellent talk.
Oh, thank you. Yeah.
I have a question. Following these procedures, especially for endoscopic stoma revisions, do you treat them as any other bariatric patient, such as sleeve of bypass? Meaning that do you keep them overnight? Do you observe for any changes? Do you get any swallow studies, or are some people treating them as day surgery?
Yeah. So that's a great question. So we kind of almost treat them as day surgery. So probably early on in your experience, you're going to keep everybody overnight because you're not sure. Wow, I placed that giant suture through the small bowel wall. I'm not sure what's going to happen. And they uniformly all usually do well. I think the key thing is when you start off, you just have to kind of get familiar with the equipment and what it can do and what it can't do. The other thing is that's really important. When we see these patients for revisional surgery, you bring them in as a new patient. A lot of these patients will come from outside programs. So you take them through your medical weight loss class. You take them through all the things you would do for a normal pre-op patient, and then when you get them to surgery, hopefully they will relearn some of the good habits they've had in the past, and this kind of restriction on their eating really helps them. We see that patients that get no education, they just get the procedure done, probably do okay initially, and then they get that weight regain again because that mechanism is definitely not as strong as the original Roux-en-Y gastric bypass.
Okay, great. Now, I know, there's some individuals also looking at performing both the stoma reduction as well as a reduction of the pouch itself.
Yeah.
Are you practicing that as well, or?
Yeah, so prior to me moving to Hawaii at Ohio State University, I would actually reduce the stoma and the pouch down. You want to give them everything you can do. So if you're using a suturing device, you can suture down the side wall of it. You can suture the stoma closed and everything. And with the new studies that just came out, I mean, these studies are not, I think some came out in the last few weeks. We know that probably per string reduction of the stoma is more effective. And then reducing the side wall of the pouch or trying to reduce the volume will definitely help out. Yeah, what the patient needs to feel is when they eat 1 or 2 bites of food, they feel full again. And I think a lot of them lose that feeling, and that's how they kind of slowly regain this weight over years.
Great. And we actually we have one other question here from the chat room. One individual states, do you offer these procedures to the patient who's had weight regain as a first-line approach, or do you try diet and exercise first, and then trying to see if they have a compliance issue?
Yeah, so that's a great question, Dr. Khan. So what I would do first is definitely, this is the way we kind of approach things. So when somebody comes back in, either from our program or some other program, definitely diet and exercise first. We try that for maybe 6 weeks. Next thing we go to after that is medical weight loss with the Adapexes, the Belviques, Qsymia. That's a great adjunct to get them to lose weight and not feel hungry. And, if they really want something more substantial than that, the next thing is endoluminal pouch revision or stoma revision. And then the final thing is or laparoscopic, gastric pouch reduction, reanastomosis. But that's I mean, in the hundreds of patients we see, maybe we've done it once or twice, because when we got into the stomach was the size of your fist, you know, in the 200 to 300 cc range, and we couldn't really do anything with that. So.
Great. Okay. All right. Well, thank you so much. Hopefully you'll be able to stick around for the last 15 minutes so we can have a panel discussion if possible. Okay. All right. Great. So next up, we're going to have Dr. Santiago Horgan. Again, he's professor of surgery and director of the Center for Future Surgery at UC San Diego Health. And we're going to be discussing some endoluminal barriers, and one particular is ValenTx. Dr. Horgan, if you're there, take it away.
I'm here. How are you guys?
Great, great. Thanks for joining us.
I am sharing the screen right now.
Yep, we can see it.
Okay, perfect. So we're going to play mode. Okay.
Looks great.
Well, thank you so much. I cannot agree more with Dean in terms of reoperations. You really need to reevaluate those patients when they come from an outside institution to your program before you do anything. And that's also true for ValenTx. So I'm going to talk about endoscopic gastric bypass. These are my disclosures. I hope they will not impact my presentation. They shouldn't. I've been involved from day one with ValenTx. That's 10 years ago that we've been working with over 70 patients operated, and I will show you some of the data. I see that this has been shown before. There is a lot of room for improvement in terms of surgery for bariatric surgery, for obesity. Endoluminal treatment has the potential of attracting patients that are not coming to the clinics right now. I have the opportunity to talk to Wall Street people beginning of this year, and I asked them if I am the CEO of a company called Bariatric Surgery in the U.S., and in 15 years I was only being able to raise the number of surgeries by 80,000 in a country where we have 20 million people with obesity. What do you do? And they told me, we fire you. You are ineffective. So I think that we all need to agree that we are not attracting patients with neither the band, the balloon, the sleeve, the gastric bypass, or the abdominal switch. I don't know why we're not attracting them, but they are not coming in the way they should. And maybe endoluminal treatments have the potential of bringing those patients to the clinic, starting the process, and then making them aware of other options in terms of invasiveness. So a lot has been shown already on endoluminal. I'm going to just discuss the endoluminal gastric bypass. In essence, what we do is we go endoscopically, we place an overtube into the duodenum. Then, as this picture is showing, we will deploy the sleeve. We do this with water. We pressurize the chamber, and we deploy around 500 ml of water that deploy the sleeve. And as you can see here, this process right now is pretty straightforward. We have it down to around 10 minutes. In the last patients, we are 100% efficient in doing this. And then we bring the cuff into the GE junction, and for now, we are placing transmural anchors. I will show you later the stent. This stent promotes ingrowth. The upper centimeter is uncovered, and the goal is that this will eliminate leaks throughout the size of the stent, creating gastric absorption. So this is in essence what we do. We look forward that peristalsis will be the one in charge of pushing food down, and then the stitches are placed purely endoscopically into the wall of the esophagus. So in essence, what we do is we do a gastroduodenal sleeve. It's around 140 centimeters long. We anchor it to a GE junction. Initially, it was endoscopic and laparoscopic approach. Now it's fully endoscopically. and mimics in the data that I'll show you later the results of a gastric bypass. This was published by our group. Brian Sandler was the PI of the study in surgical endoscopy 2015. And in the first set of patients, we saw a 42% excess weight loss at 12 months. In the first presentation, you saw today that the FDA requires at least 25% of excess weight loss. So we are way above that number, and we are in a comfortable zone with this. We achieved great response in terms of type 2 diabetes and great resolutions of the other comorbidities, as you can see in this slide. So first experience was very positive. This is the platform we have right now. It's a fully endoscopic approach. You see in the upper part of the pictures the overtube, and in the lower part, the needle holder. This is the one that deploys the stitches into the esophagus. So these are the anchors. They are made of nitinol. They expand once they became heated with the body temperature, so they are deployed through the esophagus, and then they expand with time, creating that anchor for the stent not to migrate. We place, at this time, 8 of them outside of the esophagus. Let me see if I can. Sorry for that. So this is the procedure. What we do first to avoid implanting the stent in a different place, we will mark the esophagus 2 centimeters above the G junction with ink. This process takes around 3 minutes to do. As you can see here, we will mark the 8 stitches that where you need to fire the staplers later. After we do this, we will deploy the sleeve. We will place the overtube, as I said earlier, into the duodenum. And once into the duodenum, we will fire. You can see the overtube there. And you can see the beginning of the sleeve. And with water pressure, we'll deploy the sleeve. And you can see here how the sleeve is deployed. We use the C-arm to make sure the sleeve is fully deployed. Then we will release the stent near the markings. You can see them there. And then we do a forward throw anchoring placement. So we will suck the wall of the esophagus inside. You will see that in a minute, and fire a stitch from the upper part of the esophagus inside the esophagus. You can see here, this is the stent. That's the marking of the stitches. We're going to place the first anchor now. We are going to aspirate the wall until we reach the midline. You can see the wall of the esophagus there, and then we fire the stapler, the stitch from here in. You can see the tag, and the stitch has been fully fired. So we go counterclockwise or clockwise, and we continue placing the stitches in all the positions. You can see the T-fastener there. We move the device another 10 degrees. We suck again the wall of the esophagus. In the midline, this is a stent. This area promotes growth, and then we fire the second stitch. We rotate again, and we continue doing that until we have reached all the areas. Again, you can see that we want to reach the midline when we suck the wall of the esophagus, and then we fire the T-fastener. Fourth anchor, I'm going to go fast here. And this is the post-implant view. We do endoscopy, and you can see the stent has been deployed. The sleeve is there, and the anchors are in place. Then we will remove the suture there. And on day 1 of the swallow, you can see that there is no leak around the stent and how the contrast moves through the endoscopic gastric bypass. This part was very important to us. I will show you some data in a minute. The lack of leaks through the side of the stent is a success at this stage. This allows us to really being able to capture all the food and not lose weight loss because of that. So it's purely transoral endoscopic procedure without any laparoscopic assistance. We implanted 32 patients endoscopically, 24 were female, 8 were males, 3 clinical sites. The average age was 37 years of age. BMI was 42.5. And this is the clinical data. The 12-month follow-up complete in all the patients. We fired 256 anchors in the esophagus safely in this trial. The ratio male-female was 8:24. 4 patients had diabetes and 8 patients had hypertension. Now this is very interesting. The excess weight loss was 45%. Total weight loss was 17%. All the patients were off diabetes and all the patients were off hypertension medications. Now when we look at the 2 groups on the side, the upper group is the data as a group with leaks. The lower group is the patients that didn't have a leak, where we look at weight loss. If you don't have a leak around the stent, what is your weight loss? And the weight loss was 53.6%. Very comparable with a regular gastric bypass or a sleeve gastrectomy. This is why now we have the uncovered stent to really guarantee 100% lack of leaks around the cuff. So what are the future directions? We are following this patient's up. We started around a month ago in Monterrey, Mexico, the new trial with the stent that is uncovered in the upper centimeter, and we will follow this up. Then to implement improvement to simplify the procedure and try to improve the diabetes for more than 2 years, and hopefully next year initiate the U.S. clinical trial. Thank you very much. Hello?
Can you hear me?
Oh. Yes, I can hear you.
Hey, Dr. Horgan, excellent speak. I have one question. I know in there was FDA trial in terms of the endo trial where they had some issues with hepatic abscesses, but I believe at that time the device they were using was implanted closer toward the pylorus and the duodenum. Have you seen any of these complications in terms of these abscesses anywhere in your experience?
No, you are right. That was the duodenal sleeve. Mm-hmm. They were placing it in the duodenum, and they have issues with portal translocation of sepsis. This is a different company, of course, but we didn't see mediastinitis or infections because of these 8 incisions. I think that this matches up very well with what we are seeing with POEM, right? We are doing opening in the esophagus to treat achalacias. We go through the mediastinum. We come back. The scope is dirty, and we don't see mediastinitis in those patients either. So I think that the body is much more tolerant than what we thought 10 years ago.
Sure. Okay. What's the longest duration of time that the device has been implanted in an individual?
We have patients now that have the device implanted for 2 years.
2 years. Wow. And then have you followed up any of the weight regain after the device has been removed?
We have not. I don't have the data to give you. Yes, we have. But that data is closed right now. The trial is happening in Mexico, Monterrey, and we are blind on that number.
Got it. And then kind of one last question from my end. Has there been any incidences of, kinking of the tube itself, patients presenting with any type of bowel obstructions, anything along those lines?
That's an excellent question because in this trial there was a change in the sleeve. An area of the sleeve was created tighter, much more rigid, and now we saw 2 patients with kinking. So we are going back to the previous device, the one that I just showed, where we didn't have any kinkings. And I think that we are learning that the sleeve needs to be very, very soft. Otherwise, you get kinkings on the straight part.
I see. Okay.
Yeah.
Very, very interesting. Well, thank you so much for your time. Hopefully you can stick around with us toward the end as well.
Okay. Thank you.
Thank you. All right, now just moving on here. Next is going to be Dr. Erik Wilson, Professor of Surgery and the Medical Director of Bariatric Surgery at Memorial Hermann Hospital, and again the Division Chief of MIS and Elective General Surgery over at the University of Texas Medical School in Houston. And he's going to be discussing some of the more emerging devices that are going to be coming down the pipeline here in the near future. Dr. Wilson, you there?
I am. Excuse me, I am. How are y'all?
Great, great. Welcome. Thanks again.
All right, pulled up my screen. Are y'all seeing it?
Not just yet.
Okay. Let me double check. Share my screen. Okay, I'm getting it now.
There we go.
Is it working now? Now y'all seeing it?
Yeah, it looks great.
Okay, here we go. All right, well, I'd also like to thank everyone for allowing me to participate in this. I think this is an exciting topic, and I think that the previous 3 discussions have all been very telling about where we're headed in the future. So I guess my job is to talk about even further in the future what Santi just talked about with ValenTx and barrier sleeves is something that's very interesting as part of the future because it's not FDA approved. So I'm going to try to summarize what is FDA approved, but here's my disclosures. I have worked with quite a few of these companies, including Reshape. I work with Apollo. I'm a consultant with them. I've worked with Ethicon and Gore, some of the other surgical companies, as well as robotics companies. So, but I'll try to keep my comments as unbiased as possible. Santi talked about this just a minute ago. He said, we're not really hitting the bar very well when we talk about surgery. About 17 million people qualify for surgery with a BMI over 40, and we operate on less than about 1% of that, maybe just over 1% of that. And then if you look at BMI between 30 and 40, where a lot of these endoluminal procedures exist, you're talking about 70 million patients. So there's a whole bunch of patients out there with this disease, and we're missing it. And, we have this treatment gap between medications and surgical procedures, kind of the accepted surgical procedures, and we're going to continue to evolve those and get those better, I'm sure. But we have a whole bunch of patients that don't want the surgery procedures that we currently offer, and medicine is not being aggressive enough for them. And so that's where these endoscopic procedures or endoluminal bariatric therapies, I think, have real benefit. But before I go to the future, let me kind of go back a little bit because I want to talk, I think the history of primary weight loss through an endoluminal approach is important to understand because it really sets up how procedures are evaluated and approved by the FDA now, and we need to understand that as we look at a lot of these studies, because over the next several years, what you're going to see is more and more sham-controlled trials and trials coming out evaluating endoluminal procedures and endoluminal devices for weight loss, and we need to understand kind of the background of that. And the first primary endoluminal procedure for weight loss was this toga sleeve stapler. It was a company called Satiety that made it, and it was a transoral gastric stapler. It basically went down the mouth and stapled the stomach into a sleeve-shaped configuration. But for those that are familiar with what a vertical banded gastroplasty looked like, that's what it really looked like. It looked like a stapled sleeve, and this is what it looked like on barium. Basically, it created a sleeve. It excluded a large portion of the stomach, and then it had an outlet down near the incisura angularis, which emptied in the stomach. So it was to mimic a sleeve gastroplasty type procedure with a stapler, and it was a pretty quick procedure. You could do it in about 30 to 45 minutes once you got adept at it. It was a pretty elegant device. It was definitely full thickness in the way it stapled. And the early procedures, and these were done in the early 2000s, these procedures were piloted in Belgium, Italy, and Mexico, and they had pretty good weight loss. And the excess weight loss approached 50% excess weight loss in the patients excuse me, that would normally qualify for bariatric surgery. So it improved quality of life, and it improved hemoglobin A1C. So what they did is they said, well, now it's time to do a trial in the United States and get this approved as a primary procedure. So there were 9 centers with about 23,000 patient requests for about 275 patients. And this was the first pivotal trial that had a sham-controlled arm. So 2/3 of the patients actually got the procedure, and 1/3 of the patients were sham, meaning you did a scope, you put a bougie down, but you sat there for 30 minutes as opposed to actually doing the procedure. This is what they negotiated with the FDA, and this is what the FDA said was the best way to do this trial. And we were intimately involved with this, so we got to personally experience all of this. And we had 6,400 requests just in our area alone. So it was a very, very popular procedure, and we did 50 patients. So for 6,400 requests for 50 patients, it actually got done. So very popular concept that people wanted. And what you saw when you actually got the data back at 12 months is that we actually met the endpoints for the study. The 12-month excess weight loss was 23% versus the sham, which was 14%. So the sham patients actually had very good weight loss, 14% excess weight loss, basically meaning they were getting good follow-up as they were supposed to as part of the protocol. And greater than 25% excess weight loss occurred in 44% of patients versus 20% for sham. Less than 25% was 56% of patients versus 80% for sham. In the adverse event rate, there was 1 esophageal perforation and 1 gastric perforation. The esophageal perforation was a device issue that was corrected and was set up in a way that it wouldn't happen again. But anyway, from the standpoint of the company and what were agreed with the FDA, they felt that the endpoints were met. But it didn't come out. It actually didn't ever get approved. And the reason is the company spent about $80 million developing this device and doing this trial. But the feeling was at the time these should really be just as good as surgery, and they weren't. They didn't develop that type of weight loss, excess weight loss of 23%. And so even though the primary weight loss measurements, the primary endpoints were met, they didn't feel like it was going to be a big enough difference, and so they felt like the FDA wasn't going to approve it, and they decided to shut it all down. The FDA never actually made an argument about it one way or the other. But the most interesting thing about all this data is this slide right here, which looks at mean excess weight loss by study arm. And there's 3 patients. There's the control patients in green, the patients that actually were in the treatment group that got the procedure, and then there were the roll-in patients. Now, the roll-in patients had the best weight loss, as you can see. And these are the patients that actually knew they were getting the procedure. The patients that were in red, they didn't know they were getting the procedure, so they were trying to figure out for the year whether they got them or not. And then the control patients also didn't know, and actually there were patients that lost a lot of weight. We had one patient in our group that lost 110 pounds, and all they got was a bougie put down their throat for 30 minutes. And so that's the trials that are currently being used, and that's still the way that these sham control trials are being done. And what I want you to understand is when the patient knows that they have the procedure and they have a lot of buy-in to the fact that they've got the procedure, they'll have different behaviors than the patient who's trying to figure out if they have procedure. So there's some inherent flaws with a sham-controlled trial, but these aren't going to change. This is how these trials are going to be done. And my point is when you look at these trials that come out, you need to understand that the weight loss you see in the trial is going to underestimate the actual weight loss you're going to see in real life. And that's an important thing to understand going forward, because it's real easy to evaluate these procedures and then blow them off and say they're not that effective. But in actual life, real life, when you have people engaged in the process, you're going to have better weight loss. As a result of this whole thing, the ASMBS put out a position statement that said we should lower the bar around efficacy if we have a very safe procedure that's done endoscopically. And they put out a paper between the American Society of Gastroenterologists with ASMBS saying basically a lower weight loss would be fine if you had lower risk. And that's resulted in us being able to evaluate these options in a broader sense for lower BMI patients. And just like Caitlin was talking about, balloons are being done between BMI 30 and 40. That's the primary indication. But there's other balloons out there. There's things like adjustable balloons. an ellipse balloon, which is basically a balloon that dissolves on its or leaks on its own and passes on its own. And then other obstructing devices in the stomach, such as the transpyloric shuttle by Baranova. And then there's other therapies that Dean has talked about, such as in the revisional side, but can also be used for primary, suturing or plicating devices, aspiration. And then on the small bowel side, there's things like barriers that Santi talked about with the endoluminal bypass and the endobarrier, which is a duodenal bypass, which was just mentioned that had some liver abscesses. And then there's duodenal mucosal resurfacing, and then actually endoluminal magnets to create anastomoses and bypass the bowel. So we're going to talk about some of these. First of all, the adjustable balloons. That's the most common balloon for that is the SPAS balloon. It basically has a catheter that you can pull out of the mouth, and you can add more fluid or decrease more fluid depending upon the patient's tolerance of it and how well they're losing weight. So it's an adjustable concept like a lap band, but with a balloon, and you would go in at a period of time after you place the balloon. You leave the balloon in for a year, but you have one time where you go in and make an adjustment depending on how the patient does. And these adjustable balloons may allow for longer placement, possibly better tolerance, but they would have more cost because they have more endoscopy involved. So you'd have 3 endoscopies as opposed to just 2 to place it and remove it. So that's coming on the rise, and they're in FDA trials right now. There's an intragastric swallowable and absorbable balloon, meaning you swallow it just like the Obalon, as Caitlin has described, but instead of going and retrieving it endoscopically, this one's fluid-filled, and it actually has a system where it leaks on its own. It has a suture that holds the balloon full. The suture dissolves over a period of time, and the balloon actually leaks and passes out on its own in 4 months. So you leave it in a defined period of time, and it automatically deflates. It's set up to be done for 4 months right now. It's in FDA trials, which are currently being set up and being done. So it's easier to place, possibly easier to remove, a less cost even more because you don't use any endoscopy. And you have to think about, you don't even actually need a gastroenterologist or surgeon potentially to do this. So something that really kind of changes our perspective as proceduralists as it relates to weight loss therapies. Now, endoluminal suturing, Dean talked about this as it relates to outlet revisions, but it can also be used in a primary standpoint to basically pleat or plicate the stomach to mimic the appearance of a sleeve gastrectomy. And the first procedures were done by Roberto Fogel out of Venezuela, and he showed decent weight loss in patients with lower BMI. And excess weight loss doesn't mean as much in lower BMIs because it can look really, really good with a small amount of weight loss because you're talking about smaller amounts of pounds. So if a patient loses 30 pounds and their BMI is only 30, that can result in an excess weight loss of close to 100 or even higher. So total body weight loss is actually probably a better way of measuring people's response to these procedures. But anyway, he showed in lower BMIs it worked okay using the barred endocinch device, which was the first endoluminal suturing device. But it was more mucosally based and not as strong as some of the other devices we have now. The TRIM trial, and this is a pass on that, where they basically did a trial looking at utilizing that device, and they saw some weight loss. Now, the POSE procedure is basically using the same device that Dean described, but using it for primary weight loss to reduce the size of the fundus and also create some sutures on the antrum. And this is what it looks like. You do some plication suturing, and this is a device that allows you to pleat the stomach, but not sew 2 pieces of the stomach together. So it's a pleating, but it has a pleating device, but it has very strong baskets that make it very durable in where you place the sutures. So you place sutures on the fundus, and you place sutures near the antrum, and you create some gastric emptying issues that create satiety. And there's been lots of pilot studies, again, outside the U.S., that showed good excess weight loss. These are 4 trials that were done, including a U.S. registry trial. And this resulted in an FDA trial called the Essential Trial, which was published and presented last year at Digestive Disease Week. Again, a 2-to-1 randomized sham study, just like what I showed you with the TOGA study. And it was for primary patients with a BMI between 30 and 40. Now, the weight loss in this wasn't quite as impressive. The percent total body weight loss was 4.9 or about 5% versus sham, which is 1.38. And what they did in their study trial is they designed it in a way where there was very little intervention after the procedure. They wanted to see just what the procedure itself did. And that's why the sham patients didn't lose much weight. But because of that, they didn't have a lot of follow-up around the patients. The treatment patients also didn't lose as much weight. And so this got presented to the FDA, and the FDA said, no, you didn't meet your endpoints. And therefore, they said it was safe and durable, but it didn't have a strong enough efficacy to approve it this time. So they're reevaluating what they're going to do. They also did a randomized trial outside the U.S. that was open label. The patients knew they had the procedure, and when they knew they had the procedure, they had better weight loss, 13%, which is closer to 20 to 30% excess weight loss when they knew they had the procedure. So again, you have this situation where if the patients know they have the procedure, they actually do quite a bit better. And so I think you shouldn't write off even this procedure at this point in time because just because the treatment arm in a sham-controlled trial didn't work. Like I said, it underestimates the results. Now, endoluminal sleeve gastroplasty is using another device. This is the overstitch device, and Dean talked about that when he was talking about Rattler revisions. But you can use the same device to go down and pleat the stomach with a series of sutures to basically placate the greater curvature of the stomach and foreshorten the stomach and then also reduce the caliber of the stomach into a sleeve. So you go down and you make these marking marks with argon plasma to kind of identify where you're going to suture so you can stay oriented on the greater curvature. And you make a series of sutures, usually 6 to 7 bites at a time, and then you cinch these sutures down. We usually use an in-shape configuration, and then it pleats down the stomach. And then you go back and you kind of clean up and make everything look as tubular and as small as possible with a series of sutures. So that's what it looks like with a cartoon formation. It is full thickness. I've actually done this procedure with laparoscopy watching, and I guarantee you are getting full thickness bites when you do this procedure. So it's a much stronger suturing device than we've had in the past. These first procedures were done in Panama. There were 4 of us that did these down in Panama several years ago. And what we basically took were BMI patients that had a BMI of about 33 and then followed them up for 6 months, and their final BMI was 27 with a percent total body weight loss of 17% and weight loss of 15 kilograms, so about 35 pounds. So pretty good weight loss at the first pass. And so we continued to look at these patients and evaluate them with further studies. And we felt the best BMI was between 30 and 35, but a lot of people are doing up to 40, and a few people are doing over 40. It's better to do in patients who had no previous stomach procedures, no significant hiatal hernia, and it's not like a sleeve gastrectomy to just powder and to look like it, and you're trying to make it revisable, so you focus on the greater curvature, avoid the lesser curvature, and try to allow the patient to potentially have surgery if they would ever need surgery down the road. Indications are listed here. I won't go into those too long. It's 3 basic steps. You make marks to protect the lesser curvature and identify the greater curvature. Then you hear a suturing pattern like this, and you pleat down the stomach. And then you go back and do inner rows of suturing to further pleat down the stomach, and it looks kind of like this when you're done. You don't get all of the fundus pleated down, so it's kind of the opposite of the post-procedure. Post-procedure works well under retroflexion, and so you can pleat on the fundus quite effectively. With the overstitch device currently, it doesn't work well under retroflexion. So you get what you can, but you don't get too aggressive to the fundus because we don't want to create complications. And this is what it looks like post-plication, both on endoscopy. You can see the stomach's quite foreshortened in addition to be reduced in size. And these are one of the original Panama patients. So even when we were first learning the procedure, this is what it looked like. 11 months later, when you go back and look at them later, it looks like it's opened up some. So it's not as durable as you would hope, but it is something that appears to last probably a couple of years, and I'm going to show you some more data on that. But it's revisable. You could go back and do it again. So probably not going to compete with sleeve gastrectomy, but in patients with lower BMIs could be quite useful. There's still controversies about how to do it, but we do have a basic technique that we can talk about later at some other time if people are more interested in it. There was an original pilot study done in the U.S. with 20 patients in 4 centers. We were one of those. And basically we looked at an average BMI of 33, so similar to those patients in Panama. And what you saw at a year was excess weight loss, again, between 40 and 70%, depending on whether they follow the protocol or intent to treat, and weight change between 12 kilograms and up to 18 kilograms, which looked pretty good. This has been studied in other areas. Mayo did a study. They have 12-month data that looked also pretty well. They've gone out to 2 years, and this is 20-month data with decreasing follow-up. So looks pretty good. We've done other studies, and this is the largest study now, multi-center study of 242 patients with 18 months of follow-up. And what you basically see here is 3 tertiary care centers, Weill Cornell, Mayo, and Madrid. And I think for the surgeons in the audience, and most of y'all are, you'll need to understand all of these procedures are basically being done by gastroenterologists. So we're already kind of missing the boat. And there's very few surgeons in the United States, me and just a couple others, that are doing this procedure in the United States right now. And I think that's something we need to really think about. But basically you saw a typical gender distribution, a little higher BMI in all of these patients, but total body weight loss between 18 and 20%, which is pretty good. Again, follow-up is at 30 because you're tracking these out sequentially, so we need better follow-up. And some variation between the centers. Madrid had the best weight loss, and that's probably because they have the best follow-up system and they have very aggressive medical weight loss combined with their procedure. But no significant difference between the two. And the only difference between outcomes was age. And then the patients that lost more than 15% of their excess of their total body weight loss at 18 months was 2/3 of the patients, and 1/3 did not. And trying to figure out who are the patients that didn't do as well was age, and then also their response. So if they didn't do well at 6 months, they're probably not going to do well at 18 months. So the 6-month mark is a good indicator of how well they're going to do. And if they're doing well at 6 months, they're probably going to continue to do well at 18 months. And we do not know how durable it is. I'm seeing patients that are 2 years out, and they're starting to feel more hunger, and we're going back and we're tightening them up again unless their BMIs crawl significantly. And basically their adverse event rate is pretty mild. Some fluid collections, 1 significant PE that was significant, and 1 hemorrhage that was probably due to a splenic laceration. This is a full thickness. You can't actually put the helix into the spleen if you're not careful. And 1 pneumoperitoneum. But 242 patients, that's a fairly low SAE rate. A lot of patients had nausea, so it's very similar to a balloon immediately post-op, and a lot of patients have abdominal cramps. It was a heterogeneous population, and it also improved comorbidities, and it also shortened the stomach. I'm going through this quickly. It doesn't work like a sleeve gastrectomy. You're trying to make it look like a sleeve gastrectomy, but what it does do is probably delay gastric emptying like a balloon, but probably a little more effectively because it can stick around longer. And if you look at 3 months with gastric scintigraphy, what you see is a lot of food retained in the stomach at 3 hours. 45% of the tracer still retained at 3 hours, whereas very little of it's retained in preoperatively. And the time to fullness with a meal test is significantly shorter, 10 minutes versus 32 minutes, and you consume a significant less amount of calories. So it works differently than a sleeve gastrectomy. It's not a gastric emptying procedure, it's a gastric delaying procedure. So the other FDA-approved device out there is aspiration therapy, and a lot of people have been out there joking about this as endoluminal bulimia or something like that. It really doesn't work that way, and actually the trial that came out showed pretty good results. 171 patients, average BMI 42, so higher BMI is what they're going after. They're putting a PEG tube in, and the tube has an adapter to it, so you can attach this flushing mechanism, and after you eat, you go to the restroom and you flush with water about 20% of your meal out of your tube. People think this is bulimia. It is not. It doesn't result in patients overeating and trying to purge by throwing up. There was no data that supported that or showed that in any of the trials. But we'll see. It does have a lot of bias around it, so we'll have to see. But this is the first procedure that's FDA approved that had a good weight loss and is indicated for BMIs between 35 and 55. So this is actually the first procedure that will compete with surgery. And I think it requires a lot of patient participation. And if the patients don't use the device and use it well and eat properly, it doesn't flush as well. And so the patients have to use it. So it requires lots of patient participation. So these are the patients that would probably want to have a lot of control over how they're controlling their weight. They would probably use this better. There were patients that got this procedure in the study, and they were scared to death of losing the device. And it's now agreed to be left in for many, many years. And we'll see what happens with that. But it is FDA approved. Santi talked about ValenTx, which is one of the barrier sleeves. The other one is EndoBarrier by GI Dynamics, which also went an FDA trial. ValenTx hasn't gone to an FDA trial yet. Santi's getting that device well tuned up to hopefully do that soon. But the EndoBarrier, I'm sorry, I passed that. The EndoBarrier went under an FDA trial, had some liver abscesses, and because the liver abscesses were felt to be over the expected, and it's probably related to the deployment system in the duodenum, it was not approved, and they're having to reevaluate how they're going to proceed further. But I don't think barrier sleeves are going to go away, and they're going to continue to be developed. Stenting implants, this is a device called FullSense, which basically mimics a stent to put pressure on the cardia of the stomach and create a sense of fullness. It's associated with the concept of when you put a stent down someone, they get very, very satiated and are not very hungry, actually sometimes quite nauseated. And there's very little data about this, but I did want you to know it's out there, and we'll see. Hopefully trials will be starting fairly soon on that. And then duodenal mucosal resurfacing is going down and basically ablating the duodenum, the mucosa, with hot water, using a balloon to lift the duodenal mucosa off of the duodenal wall and then ablating it with heat serially, basically with the concept of you're trying to remodel the mucosa that has changed in a diabetic. And so this is focused more on diabetes, and the early trials seem to show improvement in hemoglobin A1C, but it will probably require repeat treatments. And there have been a couple of duodenal strictures that have been managed endoscopically without surgery. So we'll have to see more of that with time, but that is out there and probably going to be offered. Ultimately, a trial will be done in the United States. We're not quite ready for a U.S. trial yet. And then jejunal ilianastomoses are also being done in Europe. This is basically two magnets. One you deploy down the stomach, one you deploy through the colon. You bring the colonoscope into the terminal ileum and up through the ileum by 50 centimeters or so, and you go past the ligament of Treitz into the jejunum. You rendezvous the two scopes together, rendezvous the two magnets together, which sounds like a really hard thing to do, but actually was done very successfully. These magnets create an ischemic anastomosis between the bowel, and the magnets basically just fall down into the bowel and are passed out on their own. And it's been a very safe way to do an anastomosis. There have been no associated leaks with doing it so far. So the feasibility around it looks very good. There'll be some variability between the anastomoses, and we have to see what type of effects. And they're going to look at diabetes resolution with this procedure as well. So basically doing a jejunal ileal bypass. And if you could combine that with some of these other procedures like endoluminal sleeve gastroplasty or other endoluminal sleeves or barrier sleeves, you can imagine how you can get quite powerful with endoluminal therapies that could compete with surgery. So there's a lot out there that's coming down the pipe. And then all of this gets a lot easier when we have flexible endoscopic robots. And the video shows this SP robot, which is Intuitive's first pass at a single channel robot, but it's not flexible yet. But they're hoping to take this device, and I know they're working on taking this device and putting it on a flexible shaft. And you can imagine how powerful it can be if you can use a digital platform to drive these instruments very precisely. The other two are the Med Robotics flexible endoscopic platform, and then Aurora is also working on a flexible endoscopic platform that might even be out for thoracic therapy in the next year or so. So these endoluminal robots are on the horizon. So to conclude, I think the future is bright for all bariatric procedures. That includes surgery and endoscopic procedures. But flexible endoscopy is becoming a larger part of surgery. And we need to be well engaged as surgeons. As Dean said, we really need to be involved in this quite closely because this is becoming a bigger part of surgery. The FDA endoluminal trials that are out there are going to underestimate the actual results. So when you're evaluating these trials, when you see them in the papers, when you see them in the journals, make sure you don't just automatically write them off. And surgeons have to grow their advanced use of flexible endoscopy as these procedures come. Gastroenterologists are going to learn all of this stuff, and they're going to create bariatric practices. And we got to make sure we don't duplicate the path of the cardiac surgeon, where everything gets referred from the cardiologist to the cardiac surgeon, as it relates to bariatric surgery. Thank you for your time, and I appreciate the opportunity to speak.
Hey, Dr. Wilson, thank you so much. Sal Docimo here, Stony Brook. So one question, actually, Dr. Halbert threw out was, she mentioned that she's read about the gastric vest, and she's saying it was an implantation device that's implanted around a plicated stomach. Do you have any experience with this device?
I do not. I do know that it's being evaluated. I have very little information about it at this point. They're trying to do some pilot studies on it outside the U.S., and I haven't heard of any current work being done on trying to create a pivotal trial yet, or a trial inside the U.S. or an FDA-approved trial. So I think they're still working on pilot studies, but it's basically a tube where you go down and have a special spiraling suture to create a sutured type sleeve, very similar to what I showed with the toga procedure at the beginning of the talk. But I don't have much data beyond that.
Okay. You know, one of the issues even I see in my practice, and I'm sure others have seen, is that especially for these newer technologies that are coming down the pipeline here, and they finally get FDA approval, one of the huge barriers to patients is payment for these new procedures, whether they be balloon, spire cyst, what have you. Is there any way that we can, that you can foresee, or anybody can kind of get involved in order to kind of reducing these barriers and getting insurances to approve them more quickly? Any opinion on that?
Well, you brought up a question earlier about staging, and I think trying to get patients' operative risk dropped might be the best mechanism to actually get these procedures approved by insurance. I had heard, and I don't remember the insurance, but I had heard one small insurance company that's, I think it's a healthcare-run insurance company, so it was covering its own patients. But they decided for knee replacements, anybody that had a BMI over 40, they would not allow them to get a knee replacement because of their risk of, because we're trying to reduce joint infections basically to a zero event. And because of that, they wouldn't allow people to get surgery if their BMI is over 40, but they would pay for them getting a balloon to drop their BMI. And so that might be the best early mechanism. Insurance companies are basically looking for reasons right now to not pay for anything.
Right, exactly.
And so we've got a real challenge as it relates to that. And strategies, I think a lot of these companies are looking for strategies to get insurance to approve. But I think our societies, and that includes SAGES and ASMBS, we need to be more supportive of these endoluminal therapies as it relates to the coding mechanisms. And sometimes the endoluminal therapies don't always get an immediate badge of honor from the societies. And the societies, I think, that's part of the process of getting these procedures codes and payment, is that the societies say they're ready for prime time. So when we get an FDA approval, we need to get some data. I understand that. But once we get data and it looks safe, we should really try to, as societies, as our surgical societies, really try to promote that these procedures are good options for patients, because that will help us get coding more quickly.
Okay. And just a note, the phone lines are also open for the other experts on the panel, so feel free to chime in as well. But I do have a question for, especially coming from looking at the endoscopic sleeve gastroplasty. Say you have everyone there?
Yes, hello, I'm here. Santiago, how are you?
Excellent. Hi, everybody.
I was going to add something to what was just said by Erik. The future is dark. Because if you look at a company like Trax with the LINX device, that now has 7 years of FDA approval, amazing data, not approved by most of the insurance yet. I look at it from the other point. The device is right. Patients pay for it. Breast implants are not approved by insurance, and patients pay for them every weekend. So, I'm not that concerned about insurance. I'm more concerned about outcomes. if we can prove good weight loss, patients will pay for that.
Okay.
Yeah, and just to interrupt, sorry, Sal, the one thing that we didn't talk about so much tonight, but it's still a device that's FDA approved out there, is the vagus neuromodulator, the V-Block. And, this device has been shown to be safe, give very good, effective weight loss. My practice actually does, we do implant these. And, this is one of those devices that actually has gotten some insurances to cover it. In particular, the VA system is covering placement of V-Block for people who qualify for it. So it's going to be a slow process for insurance approval, but again, the data is going to really be the most important thing, and then, of course, having the societies drive this forward. So, being part, and I think it also just goes to say the importance of being part of an organization like SAGES, where you can drive these things forward to help gain approval from our insurance companies for these and obtain CPT codes that can be used. That's what something like SAGES can do for sure.
Now, going forward, I think one of the common themes that all of you guys have kind of touched upon was the importance of getting the younger surgeons still in training, experience doing endoscopic procedures. And another barrier that a lot of people have expressed is the fact that after they complete their fellowship, it's very difficult for them to go back and kind of get this additional learning. So just to use the sleeve gastroplasty as an example, say you have a bariatric surgeon who's 4 or 5 years out of practice, they want to start bringing these procedures into their practice. How do you recommend them going about doing this and getting this hands-on experience?
So I'm happy to answer that, Sal. You need to, first of all, do a lot of endoscopy in your operating room, because that's an area where you can get adept at it. So if you're trying to develop a basic endoscopic skill set, do intraoperative endoscopy. Scope every patient after you do a sleeve or a bypass, just for the experience of it. You'll learn something anyway while you're doing it, but then start to manage your own complications, learn how to use stents, and then start learning how to do these outlet revisions like Dean described. And once you're adept with something as complex as endoluminal suturing with a device such as the USGI device or the Apollo device, then you can start looking at some of these primary procedures. And ESG, what we do when we do train these patients, and I'm trying to train surgeons right now, so we're offering courses. But what we do is recommend that they've done a decent number of outlets, because you have to sew a lot. You're going to be throwing between 50 and 70 sutures when you do this procedure, 50, 70 bites, I guess, with 8 to 10 sutures. And because of that, you need to be relatively adept, or you're going to take 4 to 5 hours to do it. It really can be done in an hour once you're adept at the procedure. So it's important to go through that process, and there are people that are willing to help you. So people that are interested in that, they need to reach out to us, and we'll be happy to help. There's some really good courses at SAGES. We had one this year. We had a bariatric endoscopy course where everyone got to see a lot of this stuff. So the societies are doing a good job, both at ASMDS and at SAGES, for these types of courses to get going. But then once you get going and you really want to do some of the more advanced stuff, there's individualized courses for that.
Great. Any other panelists have any other opinions on that? How do they get the younger surgeons more involved with endoscopy?
Yeah, sure. So probably the best way to do it is, as far as Erik's way, I think you should scope everybody that you can. In some hospitals, like when I was at Ohio State, our surgeons scoped a lot. Here in Hawaii, it's a very kind of divided market. So I work with the GI folks a lot, but a lot of surgeons don't do an endoscopy because they're afraid their referrals are not going to be there. So you really got to look at your practice and see how you can help out. So I think the one difference between surgeons and gastroenterologists is the willingness to do something very aggressive. So as surgeons, we know that we perforate the stomach. That's an easy fix. We stick a laparoscope in, we'll place a suture in. When a gastroenterologist perforates the stomach, that's a major disaster. They got to find a surgeon. So being involved, like with your local GI group, will get you probably more practice and more willingness for the GI folks to have you scope too. Also at SAGES, we do have courses. We always have an advanced upper course and everything. So definitely try to take advantage of that. But try to get your hands on that endoscope as much as possible, because simple things, the more you can do that, when you get to these advanced procedures, you're going to have to rely on all the skills that you have. And the one advantage you have is if you have a major complication of a perforation or bleed, you can fix it. When the GI guys have that, they can. So.
Yeah, I mean, I think one of the, certainly one of the things working here with some, with the fellows and the residents is, as you mentioned, we kind of develop a foundation of where we just get everyone to, scope as much as possible for some of our screening endoscopies. We kind of start basics and then, work their way up in terms of, okay, let's do a biopsy. Next, let's place a clip and slowly build their skill set from the ground up and get them to be comfortable. And I think one of the other important things, certainly for a lot of the residents, is just to let them know and, have them be aware that there's a lot of great fellowships out there. There's a lot of fellowships that are focused simply on endoscopy, or there's a lot of endoscopy included in their fellowship, and that really this is the future. I mean, just looking at the presentations tonight, this is the future of surgery here, and these endoscopic procedures is the future, and there's really, I don't think there's any question about it. But then one other last question I think I also want to pose to the panel here, and if I get everyone's opinion, I appreciate it. But if a patient comes into your office today and they have, BMI in the lower end, 33, 34, and they're looking for an endoscopic procedure, what would you recommend to them at this moment in time? Would it be more along the lines of a balloon or, a gastroplasty?
So what I do, Sal, I'm sorry. Go ahead, Katie.
Go ahead. So for
Okay.
me, I have a full discussion with the patient. I think that's the most important thing. Where are their expectations? What are limiting them from losing weight? And because you talk about their diet, talk about their habits. I think that's all really important because that plays a role in which procedure is going to be best for them. I end up talking to them a lot about intragastric balloons and V-block because those are two things that I can offer them in the lower BMI range. But I also work with a nurse practitioner at our weight management center that offers weight loss medications. And, of course, I work with a big weight management system that, they can go and see the nutritionist monthly, and they can work with them very closely for diet modification. So we have a gym that patients can go to for a very low cost through the hospital system. That, and so there's a lot of options out there, and I don't always focus on the endoluminal. I want to make sure that they have a variety of support, and so it really needs to be tailor-made for the patient.
I think that's spot on. She pretty much hit all the points. From a practical standpoint, I have a medical weight loss specialist in our office. I think a lot of people are getting those. So that's obviously an option, and we engage them in that. And that's part of the follow-up as it relates to these procedures. But from a pure practical standpoint, when they come in and their BMI is between 30 and 35 or 30 and 40, and they don't have comorbidities where they would qualify for surgery because their BMI is over 35, I talk to them about balloons and I talk to them about ESG. And we end up comparing and contrasting the two. And I say they're both intermediate to temporary procedures. The balloon probably lasts, even though it's in for 6 months, its effect probably lasts longer. A lot of the study supports its effect for up to a year simply because it takes a while for your stomach to wake back up after you've had that balloon in. And when you take it out, a lot of patients will say, and Caitlin can testify to this, a lot of patients will say, it still feels like it's kind of in there. I don't feel, I feel a little different, but it feels, and it's because their stomach it's thicker and it's not emptying that well. And that's also the case, I think, with the ESG, but it lasts a little longer. It goes up to about 2 years. And so I compare and contrast those. It's more expensive to do an ESG versus a balloon. It's usually $2,000 to $3,000 more, so the cost plays into it as well. Whether they want to have something that permanently alters their anatomy or not is also a thing because an ESG may open up over time. You're still going to have those pleats long term. So some patients don't want anything that changes their anatomy permanently, and so they may lean more towards a balloon initially. But those are the two things that currently I talk about. I am talking about aspiration therapy for patients that
Sure.
want it, but I haven't had a lot of success yet. I'm still trying to work on my talk tracks for that one.
Okay.
Yeah, for me, in Hawaii, it's all about like the market and everything. So nothing under BMI 35 besides I think the ban is approved. So cash pay is a huge issue here. We do have a cash pay intragastric balloon program, but to tell them that we have to take it out at 6 months and what can be offered after is a hard sell right now. So the only thing we can offer is the intragastric balloon, but otherwise we do actually a diet and exercise program. We have this huge kind of lifestyle change program here, eat fruit, walk on the beach, and lose weight. So.
All right, sounds great. Well, listen, Dr. Halbert, Dr. Mikami, Dr. Horgan, Dr. Wilson, thank you all very much for your time and excellent presentations. And again, thanks for spending the evening with us here. Really appreciate it.
Yeah, thank you very much.
Thank you.
Having me, yep.
Great. And again, for all those out there listening, please, again, obviously at the conclusion here, please go online. There's 2 ways you can sign up to join SAGES. You can go to the website, www.sages.org /membership, or you can go ahead and call 310-437-0544 and ask for extension 110. And thanks again, and everyone have a great night. Take care.
The meeting is now over. All the participants have been disconnected.